All right. So thank you again for being here. This is a picture of Les Invalides in Paris that I took. Paris is my city. And it's not that I was born there. I was born in Tunisia, you know, where we're the master of the eggplant, better than the Israelis. But this is Paris, and unfortunately you've heard about what happened in Paris, and the French people are learning to deal with what you have been dealing for a very long time. And so it's very sad, but that's a fact of life. Now let's talk about mitral valve disease. You see, this is what Ronan was showing. Mitral valve prolapse is a strange disease. It's a repair disease. You see the same patient, 20-year-old, nothing, no prolapse. You see the same patient, 55-year-old, with prolapse because the repair system is defaulting over time, over and over again, and then they develop. And this is the big question I have for Ronan and for Bob Levine is, how do you do genetic study when the people may have the gene, but you don't see the phenotype yet? And so that's an interesting thing. So the big question between Raphael and me is voluminous MR, you have a lot of volume, bad for outcomes, severe for outcomes? So you have to separate the words. It's like interpreting the Bible, you know. The words are everything. Severe means severe for outcome. And you can have a lot of volume, but it's different. A lot of volume, and is it severe for outcome? If you look at the series of Raphael, you've seen this slide. It's the miracle of Vienna. Nobody dies in Vienna. You know, you have anything. It's the place to have the worst cancer. You will not die. So if you have severe MR in Vienna, you don't die, you live as long as everybody else. So why is it severe? It doesn't mean severe. It's not severe for outcome. And this is a contradiction with a paper we had published with Ling long time ago on outcome of Flail leaflet, where we saw excess mortality in patients with Flail leaflet as compared to the expected survival. So two different papers, and you look at that and you say, okay, how do we make the interpretation? And you've seen that comparison that Raphael has shown you. The first thing that we see is that the patient in Raphael's series were younger than the patients in the rest of degenerative MR. Degenerative MR, age at diagnosis in the community is around 70, but age at surgery for most people who are referred is around 65. So 55 is a very young age. And then the legitimate question is to say, if you take a young population, does it have an impact on the outcome that you see? The same disease, the same severity, does it impact? And that's one of the papers of the MEDA series that we published, the paper by Averinos, and it shows the impact of age. Age, you take the younger patient on the left side, and you see that the young patient with the same Flail leaflet, with the same MR, they don't die. They have a survival identical to expected. On the right side, you have the older people, 65-year-old and older. They show excess mortality. So it shows that in valve disease, it's not just the disease. It's a mixture of the disease and the age. The consequences are not just dependent on the disease, but on whom it happens. If you're older, the disease makes you die. If you're younger, the disease doesn't make you die. So having a young population is an issue. And here is what we call a spline curve. On the left side, the spline curve is the overall population, and you see what you don't need to be a doctor to see. If you're older, you die more. Okay, I don't teach you anything here. But the right side is more interesting because what we're seeing is the excess mortality is compared to the expected survival in the population. And you see that with increasing age, there is an increasing mortality here, an increasing excess mortality. So you see that you cross around 50, 55, and then it's above the 95% confidence interval, above 65. So what does that tell you? It tells you that if you take a young, small group of, you see excess rate of heart failure in everybody, the young and the old. And you see here that the risk of heart failure is evenly distributed. So what we see is in the older population with MR, excess mortality. In the younger population, excess rate of heart failure. So you have to know what you expect to see. And so the conclusion of that study is if you take 100 patients who are young, you have no chance of seeing excess mortality. So, Raphael, I'm sorry, but the study has to be redone completely. You restart 1,000 patients, old enough, and you can see the outcome, because in 100 patients, you will not see the outcome. So the second thing is atrial fibrillation. You see that arrow, the red arrow, shows atrial fibrillation in the population of Raphael. In the population of Raphael, if you say atrial fibrillation and pulmonary hypertension, the rate of all those complications is 0.3% per year. 0.3%. And in the general population, atrial fibrillation is more frequent, 0.5% per year. And in patients with MR, it's 4 to 5% per year. So what does that mean? How come there are so few atrial fibrillation in the study? And it means that if you tell people, you have to come to see me every year, and only me, and I'm the only doctor that you need to see, the people who come to see you are very healthy. And because they are healthy, they will develop less complication. If you take any type of MR, 10 years after diagnosis, 30% of them have atrial fibrillation. Here, almost nobody had atrial fibrillation. So it means that the study is biased, not voluntarily, but biased by the healthy participant bias. If you force me to come back, and I come back, is because I'm healthy that I want to come back always here. The older guy, the more difficult patient, will not come back. They will not have atrial fibrillation. Then the issue is the MR. Raphael has very much criticized the way we look at MR, but you know, Flail Leaflet is a major criteria to say severe MR. So we don't have a very difficult study when we do Flail Leaflet. He had an MVP and Flail Leaflet, and the dimensions are small. And where we think that this is probably moderate MR is because what they use is color flow imaging. And color flow imaging, look at these images. Tell me who has the most severe MR. Tell me who has severe MR. You know, I've been doing that for a long time. I don't know. I don't know among those 4 patients who has severe MR. I don't know who has the most severe MR. Very difficult to say. So color flow imaging is a very difficult thing, and this is why we advocate quantification of MR. And unfortunately, the Binner study that you've been shown, these guys don't know how to quantify it. So sure, they find it terrible because they don't know how to do it. It's like you choose the wrong auto mechanics. And so you can quantify the MR, do the PISA method, then you quantify and see the effective regurgitant orifice here calculated. And the effective regurgitant orifice predicts outcome in our own study, but it predicts outcome also in this study from Korea, and it predicts outcome in this study from Argentina. So everybody finds the same thing. As an investigator, what you want is that people confirm what you have found. Our study was confirmed by 2 independent studies. Okay? Effective regurgitant orifice predicts outcome. Safety of waiting has not been confirmed by anybody else. So let's see that. Let's see what we have. So if you quantify the MR, if you don't quantify the MR, you will not see that the effective regurgitant orifice is a predictor of outcome, and that voluminous MR is severe for outcome. So primum non nocere, no, that doesn't work, because if you let the patient alone, something bad will happen. And the issue is we look at the same studies and we interpret different way. Is the guideline-based management safe? If you follow the guidelines, are you safe? Do you do good outcome? This is the old US guidelines. Symptoms, LV dysfunction. This is the new guideline, symptom, LV dysfunction. They put 5 class 1 because they repeat repair twice. But it's the same guideline. They haven't changed so much. And so, is it okay to wait for severe symptoms to operate? Well, the first thing is, are we good as doctors to wait for symptoms and jump on the patient and send them to operate? Okay, so here the EuroHeart survey, 5,000 patients in the whole of Europe. They detect MR severe in 540. Most have symptoms. How many are operated? Less than half. Half of the patients, despite severe MR, despite severe symptoms, are not sent to surgery. So us, as doctors, we're very bad at executing the guidelines, waiting, and then making a decision, and the patient is older, and they have a worse renal function, and they have this, and they have that, and they want to wait for the bar mitzvah of their grandson, and whatever, and then we don't do it. And then we don't do it. It's not to blame, it's all doctors in Europe. It's not one center, one person, we're not good at executing. So that watchful waiting thing, what is it exactly? So what we do is this, okay? So this is the doctor, this is Raphael, he has his big gun, he's ready to shoot, that's the patient, and that's the disease. And he's saying, I'm watching you. Go on, go. Come back in 6 months, I'm watching you. And then the disease is a different idea. And what happens? He's going to eat the other guy. He says, okay, that's my next meal. And Raphael says, oh, I'm so sorry. I was not watching, I was waiting. But the guy is dead. That's it. He has only one life, he's dead. That's it, it's gone. And so what do we see? What do we see? We see when we wait for symptoms, and you wait for the symptoms to be frank, the worse the symptoms, the worse the outcome. So you see, think a little bit. You're doing surgery for symptoms. You're eliminating the symptoms, okay? The symptoms are gone, but they still speak to the patient. They make the patient die long after the surgery. So you waited for the guy to be in class 3, he's better after surgery, thank you doctor, I'm good, I'm feeling good, but he's going to die because of it. We don't understand why, but we know that in this paper of Cleveland Clinic, the worse the symptoms, the worse the survival after successful surgery. And so it means that waiting for symptoms is not good. And you know, this paper makes me very proud, because Cleveland Clinic published 10 years after us the same data. So now I'm showing you the original. That makes me very proud. So we showed that when you had severe symptoms after surgery, you have excess mortality. Okay? So you still pay the consequences. So 2 big clinics, same observation. You wait for symptoms, the patient will have excess mortality after surgery. But if you do the surgery with no or minimal symptoms, you have the survival identical to expected. And I'm asking you to pause a minute. Think about it. What you're doing is you're doing cardiac surgery for a disease that is severe. And the patient, after that, lives as long as somebody you pick in the street that never had MR, never had cardiac surgery. So what we do with this surgery with no or minimal symptoms is we restore life expectancy. We put the patient back where they were before they had the mitral regurgitation. And think about the diseases that we do the same thing. Coronary disease, we do bypass. You do the same thing? No. The patient will continue after the bypass to have MI, to have complications. So valve disease is one of the few things where we can restore life expectancy, restore people to where they were before they had the disease. So that's what we're doing. We're eliminating the disease. We're suppressing the disease. So this is why it's in green. If we operate on patients with no or minimal symptoms, we can restore their life expectancy and we can have an outstanding result. Is it good to wait for EF below 60%? You've seen that slide. If the EF is below 60%, you have excess mortality. Why would I want? If I have MR, I want to be on the orange curve. I want to be the guy who lives long. Do you accept to cause the patient to have excess mortality? I don't. Waiting for a low EF is not good. Okay? If you look at end-systolic dimension is a predictor of outcome under medical management, but look post-op. There is still excess mortality. The scale is not the same, so don't compare the two curves. But if you have a big end-systolic dimension, you still pay the price after surgery. Okay? Now, the criticism that Raphael hasn't done is, this is all nice and dandy, but this was mostly studies from the time where repair was rarely done, 50% approximately. Is it true that the indication may influence outcome in the era of high repair rates? And so that's what we published recently. And what we did is we looked at organic mitral regurgitation, and we published this year in Journal of Thoracic Cardiovascular Surgery, 1,500 patients operated at Mayo Clinic, organic MR, mostly degenerative, a little bit of rheumatic, endocarditis. And you have three different classes: class 1, class 2 due to complication, or class 2 early surgery. What do we see? Operative mortality. This is the STS predicted operative mortality. And this is the observed mortality, 0, 0, and 1.1 only in the class 1 indication. So if you operate on people with a class 1 indication for surgery, the operative mortality, although very low, will be more than in the people with early surgery. And then if you look at long-term outcome, we see the same thing. It's not a matter of repair. Here, repair is more than 90%, but you see that the class 1 is here. Class 2 complication, meaning atrial fibrillation or pulmonary hypertension, is here. You still pay a price, and this is early surgery. Class 2 without complication, early surgery. Survival is much better. Heart failure, death or heart failure, again, same pattern. If you have class 1, you pay a higher price. So here is the multivariate, but don't look at the multivariate. If you have a class 2, you increase mortality by 40% long term, and you double the risk of heart failure. If you have a class 1 indication, you increase the mortality by 90% and increase the heart failure by 150%. So even in the era of repair, waiting for these triggers of the guidelines, you pay a price long term. So if you have to do it, we do it. But is it the preferred indication? Is it the indication that makes people live longer? No. So what we have to distinguish is the indication of the guidelines. Nice. It's a rescue surgery. We can do it, but it's not our preferred indication because the outcome is bad. Early surgery is in patients who have none of these signs, and then we restore surgery, no relief, because the patients are not symptomatic, although you can argue about it. We've published with Jan Topilsky's wife data on psychological symptoms. And you see that anxiety, these people that we call non-symptomatic for dyspnea, they have symptoms. They have symptoms of anxiety, of PTSD. And when you operate, what is remarkable is they go away. So these people may have a benefit by doing the surgery early because you eliminate the anxiety of having something that you don't control inside your body. Okay? So how are we going to do it? So the first thing is we do MR severity. You've seen how we do it. This is the grading by the American Society of Echo. And when we operate on people who have a large effective regurgitant orifice, we correct the excess mortality. We can do the left atrium. Left atrium is not given enough attention, but when we look at the atrial volume, it affects survival. And when you look at the post-op outcome, post-op, under medical treatment, you see that you markedly improve outcome in people who have a big left atrium. So it's a correctable factor in that. And so how do I approach that? We have risk factors with excess post-op. That's the risk factors that are in the guidelines. EF, end-systolic dimension, symptoms, atrial fibrillation, pulmonary hypertension. And risk factors without excess risk post-op effective regurgitant orifice, LA, BNP, and functional capacity. But some of these we can transfer here if we do it early enough. And systolic dimension, 36 to 39. Yes, we eliminate the risk post-op. Systolic peer pressure just before they have pulmonary hypertension. We eliminate the risk post-op. So it can be managed in a way that we have objective markers of outcome. So repair is the key to that element. And repair, the decision if the valve is repairable is relatively easy with 2D, with 3D echo. A degenerative MR is highly repairable, and you have here in Israel outstanding surgeon to do it. And if you look at the outcome, look at these outcomes of valve repair in different centers. In our own center, durability of repair for the posterior leaflet is better than the mechanical valve. Durability of repair for posterior leaflet prolapse is better than a mechanical valve. So it is a fantastic result, and we have very low rate of recurrent mitral regurgitation. So you have to be a good center. You have to be a center of excellence with low risk, excellent Doppler echo, high repair rates, high repair quality, and early surgery in those cases is beneficial. You have the paper from Korea. Remember, in Korea, the mean age, they don't send older patients to have surgery. Why? I don't know. Is it a genetic thing? We send Ronan to Korea? North Korea, maybe, huh? We send. And they don't operate people who are older than 50. Very strange situation. I don't know if there is a genetic of mitral valve prolapse different in Korea, but they have young patients. And they see a very low benefit in the propensity score match, very low benefit in terms of mortality, more benefit in terms of cardiac events, okay, because the patients are young. In our own study, large patients with no class 1 indication, there is a benefit from early surgery in terms of survival, a benefit in terms of heart failure, but no benefit in terms of atrial fibrillation. So benefit on 2 of the 3 major endpoints of mitral regurgitation. So if I see a patient with MR, there is no risk factor. Yes, I can see the guy again, often if there is more MR, and I can delay surgery in this case. If there are the guideline type risk factors, then we do rescue surgery. It's not going to be perfect, but we have to do it. And then if we have those quantified risk markers, then it's time to move to early surgery, and there are enough and new data will be coming to do early surgery in those patients based on quantified objective data on the mitral valve regurgitation. Well, first, I'm very happy to be here. It's great to debate, Raphael, because it allows us to produce data, new data every year. We can publish new papers, so that's very good. And then the other thing is, if you're interested in valve disease, please come to New York, March 17, 19, 2016. It's the Heart Valve Society. It's a very important thing. I have the profound desire that a lot of the Israeli working on valve disease be in that Heart Valve Society. We want you to be there. Please come and work with us. Thank you so much for your attention.